Okay, perfect. So we're just running through Mod B, which is sort of your derm, sexual health, HIV, and obs and gynae placements. And just same as last time, if you have any questions, don't like feel free to sort of interrupt me or put it in the chat. I've just opened the chat now. Hold on. And again, just what we'll do is I'll give you guys a minute to answer, and you can just all pop your answers in the chat. You can DM me privately or put it in the for everyone to see, up to you. Okay, so question one. So we have a 45-year-old woman who it's her first baby, first pregnancy, 15 plus 4 weeks gestation, presents to clinic to discuss screening for trisomy 21. What is the best screening option for this patient? Let's start nice and easy. Before we even answer the question, what is trisomy 21? Um, what are we screening for? Mm-hmm.
Down syndrome.
Yeah, perfect. Yeah, I've had a couple answers in the chat, and thank you whoever typed it up as well. Yeah, perfect. Down syndrome. And the other trisomies that they really want you to know about are 13 and 18. Does anyone know what 13 and 18 are? Yeah, we've got one saying 13 is Patau, that's right. Yeah, and then 18 is is Edward syndrome. Perfect. Okay. And that's just like, easy marks. May as well know that because they love just asking just straight up what's this. Anyway, so in terms of the answer to the actual question, what is the best screening option for this patient? We've had one answer. Let's get the rest in. Okay, we've got some mix of answers. I'll give it another minute just to see what's sort of winning. Okay, so this one's really hard. I do think the majority got the question right, but it was very mixed and very split. So this one was a mean one to really start on. So quickly going over. So the first thing is just checking like what the question is. So what is the best screening option? So that immediately narrows out 3 and 4 because those are more diagnostic, and no one went for that. So that's great. And so it's between 1, 2, and 5. I think it is quite difficult. The answer is 5. What I would say here is that it's about the dates. So it's because she's slightly beyond what you could do for your combined screening. So everyone who put 1, you were thinking in the right lines, especially because, to be honest, I didn't mean to, but I maybe threw you off by saying about the other trisomies. But we're not doing combined screening this time because she's slightly beyond what you would like, beyond the dates that you would do that for. So that's your combined. I'll go on to it on the next slide. So yeah, we're actually doing your quadruple test. And so that's your 4 serum tests. Now, the dating scan, I would argue, isn't really part of the screening here. Really, the screening that you're doing is the quadruple test, which is just a serum test. You would also have a dating scan. So I think it might have maybe thrown people off that it had dating scan in there. Technically, that wouldn't be part of the screening. It's just the serum test. Okay, so a little bit more detail. So she hasn't already had, well, okay, so I don't know. She does have the 15, so I've had it just for the context. I've had a very sensible question saying, hasn't she already had the dating scan? Because you got this 15 plus 4. So arguably, yes, which again is why it's not really the dating scan that is the answer. The answer here is quadrupled. I didn't make these slides, so when I was looking through it, I was like, should I get rid of the dating scan? The answer is actually just the quadruple test. So ignore the dating scan. That was maybe just to throw you off because, yeah, so maybe that's our mistake. because yeah, she probably has already been dated if she knows what her gestation is, but potentially she might not have, because surely if she had her scan, she would have also had probably been offered combined testing. So sometimes people do present a bit late. So maybe the 15+4 is us guessing based on like her last menstrual period or something like that. So maybe she hasn't had the dating scan. It's hard to say from here, but it's not a bad question. Okay, so just going over our Down syndrome screening. So there are two opportunities to do the screening, not the diagnostic, and that's your combined test, which is a little bit earlier. So in terms of what to remember, I would say ignore this. You should probably know the three things that they're actually testing, but you don't need to know like which is high, which is low. I've never seen that come up. I think that would be really crazy mean. But what you do want to learn is the weeks that you can do the combined test for, so 11 to 14. And you want to know kind of what these three things that are involved in the combined test are, because I have seen that come up on SBAs. So you've got your nuchal translucency, which is what I always thought of as in my notes. Literally, I was looking at it today. I just wrote neck juices. So that's part of your scan, and then the other two is your serum test. So serum beta HCG, which would be quite high for Down syndrome screening, and then PAP A. And then the other thing that's worth noting about combined testing is they also test for these other trisomy syndromes. And then with your quadruple test, ignore the triple, because we don't really do that. But with the quadruple test, it's a little bit later on. So it's for people who maybe missed the boat the first time around with the combined test. And it's purely just a serum test, but it's not as good. The other thing is that there is another screening test that you can do, which is called the like NIPT. So it's just non-invasive screening, but it's not offered on the NHS. But you might come across that. You might have already come across that in your placements, people mentioning that. It's sort of, and then after we've done these screening tests, only if someone comes back with like a high risk, then you would go on to like your chorionic villus sampling or your amniocentesis, because those are invasive. And so if they're invasive, they have a risk of miscarriage. And so you're not going to potentially harm the pregnancy unless you think that you've got to risk balance it. And so we wouldn't offer that before we already thought, oh, this might actually be a high risk. So that's something. Okay, moving on to question 2. A 61-year-old male with a history of HIV attends A&E with a generalized tonic-clonic seizure. He's febrile, and previous notes suggest a poor compliance with ART, antiretroviral therapy. Lumbar puncture reveals clear CSF with mononuclear lymphocytes. Opening pressure is high, and normal glucose, normal protein. So what is the most likely examination finding? Okay. Mm. Okay, again, a little bit split. Seems like everyone is jumping between 4 and 3. Okay, so this one I also thought like, wow, this is really hard. So thinking about what do we think that the CSF findings are suggesting? Um, you don't even have to be specific about the actual organism, but vaguely, what does it suggest? Exactly. So I've had a message, fungal meningitis. So the CSF doesn't match up to like your bacteria. It doesn't really match up to your TB or your viral. And so you're thinking along the lines of fungal. And then I've had another more specific answer that we're thinking cryptococcus. And that's really good. And so hopefully you'll remember this from first year, because it's one of the only things that I remember is like with cryptococcus, that's your India ink stain. And so that's why we get to the answer of 4. So it is a really tough question, because it's not just asking, like it's like a multi-step question. It's not just asking what's the organism, which I think is already quite a difficult thing to know, but it's asking a bit beyond that. And so this is all about your sort of AIDS acquired um, AIDS related diseases. And so it's sort of, I know why people were going for, well, yeah, I know why people were going for 3, but it's just about, I guess, knowing that like cryptococcus is the one that's going to be causing the meningitis, toxoplasmosis, it's a sensible thought because you're thinking, oh, they've had a seizure. So it's only because it's a meningitis that I would lean more towards cryptococcus, because otherwise, if they just said seizure and nothing else, then I would also be thinking toxoplasmosis. But I haven't really heard of a toxoplasmosis related meningitis. It's always the cryptococcus. Okay, and so I just wanted to quickly go over your CSF interpretation because I know that it's maybe been a while since you've looked at it, and just to explain the previous slide with why we were narrowing it down to cryptococcus, that it's because the way that I always first do it is, does it line up with my bacterial? Because obviously most of the time that they're giving it, it's bacterial. And so that would be if it's cloudy, so it was clear in the previous question, if it was neutrophil predominant, you've got this really high white blood cell, high protein and high glucose, I mean low glucose. And the way that I thought used to think about that is because bacteria obviously like they multiply a lot, and so that's producing a lot of protein just in themselves existing, but then also they like eat up all the glucose, and so that's why your glucose is low. And then once you've narrowed out that, it comes down to sort of to be honest, I think it is quite difficult to differentiate between the viral and the fungal. I think in this case it's because you're looking at the list that's available to you that I think makes it more clear. But I think here it's just saying that it's between the opening pressures. But to be honest, I would actually struggle to differentiate between viral and fungal. Okay, quickly moving moving on. Okay, question 3. A 22-year-old man presents with recurrent renal colic. He also has learning difficulties, nearsightedness, and a previous spontaneous DVT. Family history includes a few relatives with recurrent renal colic. Investigations shows radiopaque stones on CTKUB and acidic urine. What is the most likely composition of his stones? Mm. Okay, you guys are really good. Every single person has gotten this right. I'll give it a few more seconds for anyone who hasn't gone through the options yet. Okay. So, before I, so the answer here is 3, which is what everyone said. Oh, it says here, I was gonna ask everyone, like, which one's the most common? Yeah, so the way that I would go about this is you can immediately rule out calcium oxalate because that's the most common and it's kind of just a bit basic. And here there's clearly more going on. This isn't like your bog standard renal colic. They've got, they've got family history. They've also got all these extra things going on. So you kind of want to rule out calcium because it's just too obvious. And like that wouldn't, they're clearly trying to point you away from that. Magnesium ammonium phosphate is also known as struvite, which is associated with UTIs. And so again, this patient hasn't really come in with any sort of UTI, and so you can rule that out. Uric acid wouldn't show up on a CT. And then it's between these three, I mean, these two, and I think mainly, I mean, sure, you can know homocystinuria and like recognize it from that. And maybe that's why you guys all answered so quickly because I was really impressed. But to me, it would just be based off of like, I think this one's less common. And it's obviously like what's the most likely. And sometimes it is just that. Sometimes the answers are just what's the most common, and it'll be to do with prevalence. So moving on to sort of your types of renal calculi. So obviously stones start off quite in the renal tract, and then they can become uteric stones or they can stay in the renal tract. I mean in the kidney itself. So it's sort of all one and the same. Um, Most of them are calcium. Sometimes they're calcium oxalate, sometimes they're calcium phosphate, sometimes they're a mix. And so just calcium. If they say what's the most common type of, so they really love these types of questions, and that's why we've got one in here because this is really common, just like the type of stone. It's strange because they don't ask the same about like gallbladder stones and things like that. They don't really ask about the composition so often, but they do like the composition of renal tract ones. Struvite, as I said, it tends to be to do with UTIs, and it can form like the staghorn calculi, which I did want to fit a photo, but there wasn't space on the slide. But it's just interesting because essentially it just fills out your renal pelvis, and so it looks quite like cool. Obviously not cool for your patient. Urate stones, that's to do with high purine. And so that can maybe be like a very high meat diet, but it can also be like if you've got a hematological disorder that is causing like a high turnover of your red blood cells. Um, and it can also, so sometimes I've seen questions where they've mentioned gout as well as like trying to put you to push you towards like, oh, they've got a lot of uric acid. Um, and it doesn't show up on a CTKUB. So that's something to bear in mind because I've seen a lot in A&E where people will have a CTKUB and then it won't show up and then the patient's still writhing in agony and you're sure that clinically this sounds like a renal stone. And so just don't rule out. They could still have a renal stone. It could just not be one that shows up on a CT. And yeah, finally, your cystine stones. So associated with this condition, homocystinuria, which is a recessive condition. And so that's why we've got your sort of family history. And it's just related to a lot of stones. And there are places where your stone is more likely to get stuck. That's essentially what this bit is talking about. So it could be like essentially junctions. Junctions is where they're going to get stuck, or anywhere along the ureter because it's a small tube and it's really nasty. I'm sure you guys, I don't know if you guys have seen it, but it's very memorable. The whole, people writhing around in agony, not able, like very agitated, not able to sit still. And essentially, you look at that patient and you're like, either they are withdrawing from a drug or they've got renal stones. It's one of the two because they're so like all over the place, they can't sit still. And I've heard that this is worse than childbirth. So like people who've delivered have confirmed it's worse than childbirth, in their experience. Question 4. An 80-year-old woman presents to A&E with acute confusion as well as a history of blood in her urine. Oh wait, before we go on to that, I do want to quickly go over with your renal stones, what is the single best pain relief that you can give your patient with renal colic? Yeah. See, a lot of people are saying I am, and so I've had this debate with someone with an A&E doctor. So I think somewhere in some guideline it says I am diclofenac. However, if you go to the urologist themselves, they will say PR diclofenac. So I think there is a little bit of debate about which one's better, but I would actually go with PR diclofenac, especially if you're around the urologist, because that's what they seem to think works better than I am. And so that's why I thought I would just quickly point that out because I had this whole debate with them where they were like, yeah, no, like the only people who seem to say PR are the urologists, but the urologists are the expert in this condition. It's just there seems to be like a bit of a lag with the guidelines. So I think the guidelines say I am, but I would actually go PR. It shouldn't, and actually, I don't think IM has actually come up in my SBAs. I've always seen PR as well, probably because the people who are writing the SBAs are probably urologists, like maybe, I don't know. So I've only ever come across PR, but I remember having this debate, and so I just thought I'd put it out there. It's PR diclofenac is preferred by the experts. Okay, question 4. So an 80-year-old woman presents to A&E with acute confusion as well as a history of blood in her urine. Bloods reveal raised calcium along with multiple well-circumscribed lesions on chest X-ray. Which of the following investigations will be most helpful in determining the diagnosis? Mm. Okay, we're getting some answers in. For those of you who have already answered, um, what do we think this is? Yes. Okay, great. So I've got lots of answers. I've got some people saying that it's cannibal Mets, some people saying it's renal cell carcinoma, all correct. Yep, renal cell carcinoma causing cannibal Mets. And so in terms of Yes, and someone's gone far further and said with paraneoplastic syndrome, so you've got your raised calcium. So the raised calcium is quite common in lots of cancers. The reason being that quite a few cancers do release sort of like a parathyroid-like peptide, and so it sort of mimics parathyroid hormone and then causes an increased calcium. So it's not just multiple myeloma, but great. And in terms of the actual SBA, most of you did get it right. So yes, it is four. So thinking about it, Anchor, we know that this is not going to be like a rheumatological condition. Like clearly, multiple well circumcised lesions on the chest X-ray. Maybe they were trying to lead you towards like I don't know, lupus or sarcoid or something. But like this to me does sound like cannibal Mets, especially with the raised calcium. Whenever I see raised calcium, the first thing you do want to be thinking about is cancer because it's just that is a common association. So you're thinking you can rule out Anchor because it's not going to be rheumatological. Um, Ultrasound, it's it's not really always the most sensitive. Okay. I'll come back to that question. Cystoscopy, that's for bladder cancer, which doesn't really present in the same way like with your classic Mets. CT chest would show you your cannibal Mets, but it wouldn't show you your actual cancer. So I've got a question about it says determining the diagnosis, wouldn't ultrasound abdo be used first line? I think this is one of those like first line versus diagnostic. So sometimes it's about the way that the wording, like the way that the question's worded. So quite often you'll see that it might say, for example, what's the first line or what's the initial management. And so maybe your first line would be ultrasound, although to be honest, I think with a cancer, you probably wouldn't go to ultrasound anyway, because you're probably going to want the CT, because also the thing is you wouldn't like you want the CT abdomen because also you're going to need a CT at some point. If you think that there's cancer, like think about it. You can do your primary thing and be all like, oh, let's do the least invasive first. And I can see that thought process. But if you do have this high suspicion, which I think we do, it's kind of just wasting time to do an ultrasound when you know that eventually you're going to need that CT anyway, because you're going to need the CT to do the staging. You know, everyone's pretty much with a cancer is going to get like a CT abdomen and chest, abdomen, pelvis. So they're going to need a CT anyway, and the CT will help you visualize better what's going on. So maybe the ultrasound will tell you something dodgy is going on. Maybe it'll even tell you you've got a cancer going on. But to really visualize it and then make steps forward, you'd always have needed the CT. And so I think most people wouldn't even bother with the ultrasound. So I can see the reasoning as to why you're thinking like, let's go with least invasive first. But like, you quite often don't see people having like something as simple and unhelpful as an ultrasound for something as serious as cancer, because you know that there's sort of this pathway in their head of like, you know, when you're making your diagnostic investigations, you need to have that thought process of like, also what are we going to do with this information? So if the answer is going to be I'm going to give them a CT abdo anyway, then like you could have just done that in the first place. So I would expect that you would just head straight there. I think if it was something like, you know, less worrisome than cancer, then sure you can go like a little bit slower, do the ultrasound. But the ultrasound might not pick it up and it won't tell you enough information. This is the thing. I have another question about how can you see the masses with arterial and venous phases? Dude, I do not know. I do not know. So I would ignore the with arterial and venous phases and just be all like, it's CT abdomen. CT abdomen, because it's the best way of visualizing. How the arterial and venous phases help, I don't know. I would just trust the radiologist when they suggest that, but no one has ever really gone over why that matters. But I think essentially with arterial and venous phases is basically like with contrast. It's CT with contrast, is my understanding. So yes, you do want a contrast CT. It just helps you visualize better because there's obviously when there's contrast, there's more contrast. You can actually see things easier because the whole point of a CT is that it's like comparing different like densities and things. So the contrast helps and it basically makes the whole thing clearer. So that's my thought process. I could be wrong though, because I don't know that much about radiology. But it's just for me, the way that I'm reading that is CT abdomen. Okay, I'm sorry. I know that's not super helpful. It's just that's the honest truth. Question five. A 25-year-old woman presents to the GP with irregular periods. On examination, you note acne and coarse facial hair. Which of the following is consistent with the most likely diagnosis? Also, I appreciate the person that DM'd me a laughing face emoji because that makes me feel seen and not like judged. Okay, everyone's getting this. So, what do we think this is? What condition? Yes. So we've got one answer. I'll give it a bit longer. Yeah. So PCOS. So polycystic ovarian syndrome. So the kind of classic irregular periods, and they've got sort of like a lot of like they've got these like androgen effects. So acne, coarse facial hair, things like that. And so in terms of our diagnosis, so the sex hormone binding globulin will be low because you've got a lot of sex hormone in the and so it will be binding. The globulin will be doing the globulin thing and it will be binding. So actually that should be low. The LH is specifically high. That's sort of what's diagnostic in your test. So PCOS is like it's an overactive gonadotropin hormone hormone release from your pituitary, and then that is causing too much LH to be produced. And so specifically what you're looking for is a high LH. And then low free, so normal FSH, by the way, is the right answer. Um, so so it should be normal because what we're looking for is an abnormal LH, but not an abnormal FSH. And quite often what we do is we compare the two. So you might have heard the whole 2-to-1 ratio. So there should be a 2-to-1 ratio between LH to FSH. And that's because the FSH has remained normal while the LH has gone up. And then low free androgen index, high, so they also have like high levels of testosterone, which is why they have this androgenism. And so they would actually have a high free androgen index. They've got lots of it floating about. And then, as we've said, like they would actually have a high testosterone or even a normal, but not a low. Okay, moving on. A 23-year-old woman, yep, presents to an after an episode of unprotected sexual intercourse 6 days ago to ask about emergency contraception. She has a regular 28-day cycle and is now on day 16. What is the appropriate management? Great, fantastic. Everybody is getting this. Okay, so just to go over, so remember that the first thing you want to do is find out when they ovulated. So you draw out like I tried to find a timeline, but I did not have time to make one and I couldn't find one online. So imagine you're drawing out like a timeline and you've got your UPSI and you've got your sort of 28 days because it's a 28-day cycle. And then you want to work backwards and figure out when they ovulated. So remember the follicular state phase can change, but your luteal phase doesn't. It's always 14. So you go backwards from 28 to 14. So they've ovulated on day 14 and we're now on day 16. So she's already ovulated. And is there a chance that she's pregnant? Potentially, because she ovulated 2 days ago and she had sex 6 days ago. And sperm can last in the cavity for like 5 days. So it is potential. So that's sort of like that's the way that they hopefully have taught you how to like think about it. So yes, there is a risk that she's pregnant. Yes, she has already ovulated. And so because she's already ovulated, that actually rules out Ella1 and 11L because both of those work by delaying ovulation. If she's already ovulated, it's too late. That ship has sailed. But the good news is that she's only 2 days post ovulation, so you can still give the IUD. And you'd want to give the IUD anyway if she agreed to it because it's the most effective out of the three options and because it's the one that gives you long-term contraceptive benefit. Um, IUS is just a regular contraceptive, but it's not for emergency. And advise her that she may be pregnant and arrange follow-up. Not necessary in this case because you can still do something. I'm sure I mentioned last time, my mom's a sexual health doctor, and I've asked her about like, what if, they've already ovulated, but they can't take an IUD or they don't want to take an IUD, or what if they're past the window? Do you just send them away? And to be honest, she was like, no, even if theoretically she's probably ovulated already and we've missed the window completely, we can't give her the IUD, we can't give her Ella 1, we can't give her 11 out. I will still give her Ella 1 or 11 out because an IUD you can't put in if you genuinely think that there's a risk that the pregnancy is like implanted, because then it would be abortifacient and also very dangerous because they could end up with like, you know, ectopics and things like that. So you can't give an IUD too late, but there's no harm in giving Ella 1 or 11L too late because it wouldn't harm a pregnancy that already exists. But sometimes people ovulate slightly, like she might say, oh, I'm regular 28 days, but she's actually like slightly irregular. Maybe she's like 1 day out or something, and she's just been very lucky. And so she's just not ovulated, even though you've calculated that she might have. So this is just out of interest. It's not really for this SBA. I just went off on a tangent, but basically explaining that you can never give IUD if you think that it's too late, but you can always still give the hormonal contraceptions because they don't cause harm. So you probably wouldn't ever advise her to just, you might be pregnant and send her away. But you obviously, if you gave Ella 1 or 11 out outside of the recommended window, you'd still want to feel like you might be pregnant and you need to come back and we need to do a pregnancy test. But you'd still give it just in case it worked. So I'm very passionate about contraception, as you might know. So yeah, sorry, I went off on a tangent. Okay, question 7. You're carrying out a 6-week baby check in clinic. Mother and baby are both doing well. She's bottle feeding. The mother tells you that she experienced some itching during pregnancy and was monitored weekly at the hospital. She was induced at 37 weeks. A couple of days after this, the itching stopped. She's asking you about contraception. Which contraception should be avoided in this patient? This one's quite tough, so I'm going to give you a bit longer. So I don't think this is anything that you guys will have been explicitly taught. I don't think I was explicitly taught it either. But, it's good to do these questions because it helps you practice sort of sensible guessing, because that's going to happen during your SBA. There's going to be at least one question where you do have to sensible guess. And so I think this is one of those. Um, Thinking it through. So she's had itching. What are we thinking she's talking about here? Yeah, perfect. So obstetric oh wow, all caps, intrahepatic cholestasis of pregnancy. Yes, obstetric cholestasis. And so that's kind of all you need to know from this. And then obstetric cholestasis, which contraception wouldn't we want to give her? Now, I've never, as I said, never been taught this. However, looking at the options and knowing what you do about contraception, because you guys are all pros. So for the record, you all got this right, by the way. There's only one medication that I think you might have learned from last year when you did your gas replacement that can cause cholestasis. And that is sort of the thought process here. So the implant, right, first of all, the IUD and the IUS, definitely rule those out because they're not doing anything. They are staying in the uterine cavity. They don't really have systemic effects. So they're not going to cause any cholestasis or any further liver problems. Um, and then the subcutaneous implant, what's in the subcutaneous implant? Mm-hmm. Good. Yeah, it's progesterone. Progesterone. So the thing is, if this one's progesterone and this one's progesterone, you can actually just figure out that the only one that out of these three that isn't like the same is the oral contraception because this one has combined, so it's estrogen as well. So you can actually rule it out just by being a bit tricky about it, but also by knowing that the combined oral contraception has been linked to cholestasis. So apparently it should be avoided. But I would have, honest to God, have just guessed it right, because we know that the COCP is a potential like cholestatic drug, just like fluclox is. Fun fact, flucloxacillin is banned in the US just because of the very, very small likelihood that it can cause cholestatic like cholestasis and jaundice, and it's kind of stupid. Anyway, question 8. So a 75, but well done, guys, because everybody got that. Question 8. A 75-year-old man presents to the GP with 1 year history of urgency, hesitancy, and a feeling of incomplete bladder emptying. There's no weight loss, hematuria, or back pain. On examination, a smooth, uniformly enlarged prostate is identified. He's hoping to attend a big birthday party in 1 month and would like medication to help with his symptoms before then. Which of the following medications will most likely reduce his symptoms before the party? Okay, Brill. So, a bit of a mix, but we mostly got the right answer. So, first of all, what are we trying to treat here? Symptoms of what? Yeah, benign prostatic hyperplasia. And so because of that, you kind of can already, so there's only two treatments here that are treatments for BPH. So you can rule out duloxetine, sildenafil, and oxybutynin. So and oxybutynin are used for like other types of urinary urgency, like overactive bladder, and I think, and then sildenafil is used for like not being able to get an ejaculation. So, or no, an erection, sorry. So, 3 and 4, that leaves you with 3 and 4. And so, this is actually a good question because it's pointing out like the fine details of your two medications. So, essentially, tamsulosin is the only one that can act quickly enough. So, it takes many months for finasteride to work because they work very differently. So, this next slide goes into it. So tamsulosin is literally working on the smooth muscle and it's just getting it to relax a bit so that the urethra has less like, pressure on it, and so it's less bladder outflow obstruction stuff. But finasteride is actually trying to shrink the size of the prostate, which is kind of a bigger job and it takes a longer amount of time. And so that's how I think of it. That like tamsulosin is sort of like, your like short-term solution, but it won't long-term improve things. Whereas finasteride takes ages, but then it does actually reduce the prostate. Obviously, finasteride also doesn't do a massive amount. I think it reduces the prostate size very minimally. So it's not like it's like life-changing, but it is, it can be very effective. Side effects. So tamsulosin, this is a really important one for your gerries, is to think about postural hypotension. So, when you're doing your medication reviews, being aware that like tamsulosin is one of the ones that could be causing your more elderly patients to be fainting. Retrograde ejaculation is something that I've seen them warn like people about, and it's because it's not harmful in any way, but obviously it might frighten people. So it's just worth mentioning. And then finasteride, just one thing about it, which I don't think is on here, is that actually finasteride is also linked to like reducing prostate cancer risk. So because I guess because it's shrinking the prostate size, so it's actually like kind of got a long-term benefit in that sense. So yeah, we can use anticholinergics like your oxybutynin, but they tend to be more for like your uh like bladder urgency as opposed to like for BPH. Because with BPH, there are more specific ways of handling that don't have all these horrible side effects that anticholinergics have. And again, same with mirabegron. These ones tend to be more to do with like things that aren't to do with the prostate, so more bladder issues. And then there are surgical ways of fixing it. You don't really need to know too much about it. With TERP, the one thing I would say is so I can't wait, hold on. I can't actually see this slide, so I can't see if it's on here. Yeah, TERP syndrome. Yeah. So that was the one thing that I would actually know about TERP is the risk of TERP syndrome because that does come up in your multi like SBAs. But apart from that, I don't think this stuff you need to know in too much detail. Okay, so question 9. A 28-year-old lady presents to the hospital at 20 weeks gestation with severe abdominal pain. Speculum examination shows heavy vaginal bleeding with an open cervical os. Some products of conception are seen in the canal. What is the most likely diagnosis? Okay, you guys are very good. This took some genuine like deep diving into things to try and figure out for me. So well done, everybody. So I think we can. So the first thing is you can. I think the fact that you've got an open cervical os is very helpful. So it means that it's not a complete miss. Well, it's not a complete miscarriage. And it's also not a miscarriage because neither of those ones would have an open cervical os. And so threatened miscarriage, you would expect that they haven't already got vaginal bleeding, like, and they might have vaginal bleeding, but they definitely don't have products of conception. Like, it's kind of like a bit earlier. And actually, the threatened miscarriage doesn't become a miscarriage. It's just like a bit of vaginal bleeding. I can't remember if the os is open or not, but it basically it doesn't move on to become a miscarriage. It's just like, be more careful. And so I narrowed it down to 2 and 4, and this one was quite difficult, and that's why I ended up wasting a lot of my day today reading about this. But between the two, you guys all got it right, which is that it's incomplete miscarriage. And so we'll go on to why. So I don't think, yeah, okay, it does say it here. So with the threatened, oh, the cervical os is closed. Yep. Thank you, because someone did also message that. And I'm seeing this. Oh yeah, cervical os open your eyes. So it's the ones that are inevitable and incomplete. I actually thank you guys. I used to use that a lot on my when I actually needed to know this, but I'm a bit rusty now. So thank you for reminding me. Now I will never forget. So threatened, as I said, it doesn't necessarily become a miscarriage. It might just be threatened, as we've said. Inevitable, there's no way of stopping it from happening. It is going to happen, but the products of conception haven't yet passed. And so I think what's tricky about this question is that normally the questions that I've seen with an incomplete miscarriage, it's slightly more like obvious because it's not just some products of conception are seen in the canal. It's like maybe they've passed some, but they can still see some as well. And so it's sort of more like in the process. But so incomplete, I would say incomplete miscarriage is basically an in the process miscarriage, whereas inevitable, they haven't passed anything yet, no products of conception. Whereas if you can see in the canal, that basically counts as it being passed because it's come out of obviously the uterus. So that counts even if they've not like seen it in a bedpan or whatever. And then complete importantly, you can't see anything in the uterine cavity. You have to do an ultrasound if you think that there's a miscarriage because it's very dangerous. So, oh yeah, it's very dangerous to leave like products of conception in the uterine cavity. And so just going back to this one, if you do see products of conception in the canal, you have to take them out. Obviously, I don't expect any of you guys to be doing that, but I'm just putting it out there that they need to be removed because you can go into like cervical shock. And if a missed miscarriage, essentially they've got a non-viable pregnancy, but they've never really passed anything, and so it can be missed for quite a while. And so those people need to be dealt with in hospital and essentially need like a termination of pregnancy to remove the products of conception. But it's not a termination because it's already not viable. But essentially no products of conception can be left in there because it can cause like sepsis as well. And so there is, it's not on this slide, but there is also the 1, 2, 3, 4, the 6th type of miscarriage, which is just like retained products of conception. I wouldn't really say that's a miscarriage, but as in it's another one that I would put here for your differentials of someone who's been pregnant or recently pregnant and is bleeding and has pain. Okay, so What is CRL? From the previous slide. Wait, my thing is covering some of the. I'm gonna be honest. Okay, someone has answered for us. Crown rump length. I don't know because I don't know how to ultrasound a baby. And but thank you very much for helping me out, Suman. Okay, and don't worry, you don't need to know that essentially, but it's just I think yeah, don't worry, you just need to be able to recognize a miscarriage in an SBA or based on a history. You don't need to be able to do any of that because that's quite complex, and it's more for the actual obstetricians. So, question 10, a 50-year-old man is admitted with acute urinary retention following a recent UTI. Ultrasound shows bilateral hydronephrosis. What is the following best course of action? Mm, okay, so people are split between two answers. What do you guys think we're treating here? Anybody? What are we treating here? Okay. Okay. Okay, good. So, okay, cool. So I think there's maybe a miss. So everyone is split between two answers, but the two answers are wrong. But that's okay. It's because you guys are actually thinking in the right lines. So that's why I was asking you, like, what are you trying to treat here? So you are thinking about the right kind of thing. You know, someone said prostatitis, someone said BPH, someone just said we need to decompress. Now, you're right. We need to take pressure off of the kidneys because bilateral hydronephrosis suggests that they're like, at risk of having actual damage from this urinary retention. However, a nephrostomy is not the simplest way of getting rid of some of that pressure. And the very first thing that you're going to do, think about it, is you're going to need to catheterize them. So no one picked four, which is actually like your simplest, your most basic thing that you guys will be doing as F1s is someone's got urinary retention and it doesn't really matter why. Like it could be prostatitis, it could be BPH. To be honest, it probably isn't. It's probably just because they've had a UTI recently. And sometimes people just randomly go into urinary retention. And like not randomly, but as in well, sometimes randomly, but also in this case, they've kind of had a trigger. So the reason behind it is not that it's the reason behind it is not that there is something. So someone's asked, so how does that treat the hydronephrosis? Because the hydronephrosis is essentially like the kidneys are getting this back pressure because the bladder is not able to empty. So if you imagine, sure, you can take out pressure by drilling a hole and putting a nephrostomy in, but the much less invasive way of getting rid of pressure in this closed system is to open it at the bottom, which is to make sure that they're not in urinary retention anymore. And then the hydronephrosis will go away. So the hydronephrosis is just a sign that like this is a closed system that's building up pressure. So it's backlog from the bladder. And so the easiest thing to do is to just catheterize them. Why is this the best intervention rather than the immediate first line? Okay, because again, this is probably just urinary retention, not secondary to something physical like stones. So This bilateral nephrostomy, and same with the stents actually, these would be things that we need to do if there was like a physical problem, like if there's a stone that we need to relieve pressure off of, or if there's like a stricture. But the thing is, we don't know that that's the case, but it probably isn't. Like this is just a 50-year-old man. They've had a UTI. They've gone into retention. So actually, all we have to do is catheterize them, let them sort of settle on their own, and then TWOC, and then send them home. Obviously, we would investigate, see if there's something else. Is there another reason why they went into urinary retention? But this is something that is surprisingly so. Like, there's not always a big reason. Sometimes people just go into urinary retention. They can just have like a small injury to their system and then go into urinary retention. And so that's why it's the best intervention, because actually we might not need these things. These things are quite invasive, and like a nephrostomy won't get rid of the fact that he just randomly went into retention because of a UTI. What would be the first line management of hydronephrosis if it was secondary to stones, nephrostomy or stents? Good question. So it depends. So essentially, the nephrostomy is the less invasive, less risky option. It's for people who are more sick. So nephrostomy is like if you got a stone that is also septic, and so your patient's quite unstable, and as someone said, acute, yes. And then if they're like elderly as well, because they won't be able to put up with a stent. And also stents are more of a long-term solution. And so the two options that people went for was the nephrostomy and the stent. But yeah, essentially your stent is your more long-term solution, and it's for fitter people. The stents only last for about 6 months. They can move, they can cause issues. So again, someone who wouldn't be able to tolerate like multiple procedures like that wouldn't be suitable for a stent. Nephrostomy is more like your acute issue. It's kind of like, you know how like your Hartmann's is sort of your like acute issue surgery. This is your acute issue for urology, is let's put a nephrostomy in to immediately drain and like get rid of this back pressure, because if we put a catheter in, it's still not going to get rid of the fact that there's a stone there. So it is only really for like if there's a stone or something like that getting in the way. So thank you guys. Very good questions. I think it covers a lot of good points here. Any more questions before we move on? Because I know that this kind of did cause a bit of confusion. I'm hoping I've cleared it up. Okay, we'll move on. Okay, so urinary retention. So as some of you said very rightly, it can be just benign it can be BPH. Could be stricture, could be stones, could be cystocele, constipation. So this is the thing. This is why it seems so random sometimes that people go into retention, especially the more elderly. They're very, very susceptible to just going into retention, and it's just because they're constipated. If there's a mass that's compressing, medications can also cause it. So sometimes it can be a neurological cause. But also in this case, it was just the UTI might have just triggered it. And so complications, this is more the sense of if it's like a more chronic urinary retention as opposed to acute, I would say, is like your post-obstructive diuresis. So I think it kind of depends, I think, on the urine output that you get when you first drain. But my understanding is that this is more likely to happen if you drain like more than 500 mils when you first put in that catheter. Whereas if it's less than 500 mils, it's not as likely to happen. But essentially, you just want to review them, keep careful monitoring. Symptoms, inability to pass urine. They should, if it's acute, they should have pain. If they don't have pain, it's because it's chronic, because with chronic, it's this slow buildup. And so the bladder does stretch, and it stretches slowly. And so kind of, it doesn't really cause any pain. It kind of gets used to being full. Whereas with acute, it stretches suddenly. And so it's a bit like if you suddenly pull a muscle or something, like suddenly do something, it hurts more than if you were to do the same movement but slowly. It's a very important cause of confusion and delirium in elderly patients. And the signs: palpable distended bladder. You can do like a bladder scan. They're super easy and fun to do because they're super easy. They might be have lower abdominal tenderness. We might need to do some neurological exams and rectal examinations. to check for causes. So it's not like we would just catheterize them and then be all like, off you go. We would obviously look for other causes, but sometimes it's not actually like anything that we can get rid of. It can just be like, oh, it happened, it's over now. You investigate like so, like you would with anyone. Ultrasound if pressures of high pressure retention, fine. And then your management. So yeah, do your bladder scan so that you can see how much there is and confirm that they are in retention. Catheterize them. That's the first thing that you can do. It's the simplest thing that can be done. It can be done in A&E. And then treat if they've got an underlying cause. And then you can just trial without catheter after that and see if they're fine. Because sometimes that's all they need is like a little bit of support from us, and then they're fine after that. The other thing, which I don't think is on here, is that with obstruction, I've seen this quite a few times, urinary retention secondary to clots. So the clots could be because they've got cancer that's bleeding, because obviously that's what we always think about with hematuria. But it can also just be because if they've had like for example, a recent like urological procedure that can cause trauma, and so things like that. So I've actually seen someone who was in hospital for ages. They were in hospital for like 7 days because they were just having horrible urinary retention because of these massive clots. And it was just because they'd had a oh my gosh, cystoscopy. And that had caused them to bleed and clot and then go into retention. So that one's actually like consider your iatrogenic causes. Okay, question 11. A 23-year-old female presented to ED with right iliac fossa pain, which radiates to her right shoulder. She also has vaginal bleeding. Her last period was 7 weeks ago. Which of the following is a risk factor for this presentation given the most likely diagnosis? Okay, fantastic. You guys are all answering pretty quick. Give it a second and then we can move on. So everyone has answered correctly. So it is PID, good. Which other, so we've got a couple contraceptions here. Which form of contraception is a risk factor for this presentation? Yes, intrauterine devices. So that could be the IUD or the IUS. And what presentation is this? Yeah, so this is ectopic. Specifically, it's probably a ruptured ectopic. Reason being that, like, with the radiating to her right shoulder, it would only really do that if it's ruptured, because then that's when it like causes like liver capsule irritation and diaphragmatic irritation, and that's phrenic nerve things, shoulder. So it's specifically like she's had a ruptured ectopic. All right, so any ectopic pregnancy is any pregnancy implanted outside of the uterine cavity. The most common site, which I don't think I've seen this come up in an SBA, but like I've had people ask me this, like doctors like to ask, is that the most common site is the ampulla and the isthmus of the fallopian tube. I can't move this out of the way to, let me see if I can. Oh, good. It does show it already. Fine. I wasn't sure if it was on the diagram. Okay. And then your risk factors. So there's quite a few risk factors. So if they've already had an ectopic, PID and endometriosis, because that can cause like structural issues like adhesions, which again are like, they make it more likely that it will be implanted somewhere that isn't the uterine cavity. The IUD or the IUS, because again, there's something physically in there. And so it could cause the fertilized egg to go somewhere else rather than in the uterine cavity. The progesterone only oral contraceptive or implant. I wouldn't personally be quoting that. I haven't made the slide, but I personally wouldn't say that. I would say like the IUD, the IUS, and surgery. So surgery to your tubes and things like that. So this is something to keep in mind because it's actually a relatively high risk. This is why not I was gonna say hot take. I don't think it's that hot of a take. It's a fact Female sterilization is more risky than male sterilization. So really, patients should be encouraged to maybe have that discussion and consider male over female, because with female, there's a 1 in 200 failure rate, which is really high. That's like a really like, so the tubes are stubborn. The tubes will do what the tubes will do. And so really, tubal surgery is not that great. Like tubal ligation is not that great, but then also it has a risk of ectopic pregnancies. So male sterilization is always the safer option out of the two. It's really disappointing because when I was on my obs and gynae placement, I saw lots of women having sterilization procedures, and there was never really a conversation about like, are you sure that you want to do this? Have you, had a conversation? I don't know. It was a shame. I personally felt quite like irritated by it, because I was like, I feel like as doctors, we just need to be giving people the right information, and sometimes that means telling them that there are better, safer, more effective alternatives. And maybe have you considered that? Have you had those conversations? Would you like us to have those conversations? Whereas I felt like it was kind of lazy medicine to just go, yeah, okay, we'll tie your tubes off, and then just like not have a conversation about the fact that there are better alternatives. Anyway, and then in terms of your in terms of your symptoms, lower abdominal pelvic pain, vaginal bleeding, shoulder tip pain, as I said, is like your referred pain from diaphragmatic irritation, which I wouldn't expect to happen unless it's ruptured, and vaginal discharge. Again, that's kind of related to your vaginal bleeding. Um, Cervical excitation, this is all to do with like, again, ruptured, because they're going to have like a peritonitic type picture. So abdominal tenderness and all that stuff, but also cervical excitation, adnexal tenderness. Um, I have seen this debate go on. NICE advised not to examine for adnexal mass because of rupture risk. But I'm going to be honest, I have seen, someone asked one of the obstetricians, and they were like, I don't know how hard you're like examining to cause a rupture, but like as long as you're gentle, like the obs and gynae doctors that I have spoken to, they've said no, I would still examine them, because it shouldn't be that aggressive that it's causing a rupture. So I think, I don't know, that one's a bit of a question mark. And then yeah, as we've talked about. Okay, and then your investigations. So I'll move on because I'm aware of the times. I have had a question. How many questions are there? We're about halfway. This is recorded though, so and I think it gets put on YouTube. So you can catch up if you are not able to stay. I think I have a feedback form at some point. I'm not sure. Can I quickly, just because I've got a sore throat and I've been drinking so much because of the sore throat, I really need to pee. So can we just quickly take a 1 minute break? Um, okay, I'm back. All right, so question 12. A 27-year-old nulliparous woman is admitted at 37 weeks gestation in labor. The cervix is 7 centimeters dilated. The head is direct OA position and is 2/5 palpable on abdominal examination. The CTG shows late decelerations with fetal heart rate of 98, continuing for 15 minutes. What is the most appropriate management? We've got a few answers, but I'm just waiting for a few more to come in. Okay, good. I think everyone's in agreement. And this is an important one, so good. Okay, so the most appropriate management, which you've all chosen, is your C-section. Reason being that there are some really worrying features here. So decelerations are always a bad thing. Fetal heart rate, crazy low. And it's also been continuing for 15 minutes. I think even after 5 minutes, you'd be really worried about this. Now, in terms of the other options here, ventouse, you can't really do that because the baby's head isn't available to you to like, like they need to be basically crowning for you to do ventouse. Oxytocin is sort of increasing your maternal contractions but that's more for if they are, what's the word? Like they've got a special way of saying it, but they're just not progressing. They've stagnated in their labor. Now, it's not really said that she's stagnating in their labor. It's not talked about being like in stage this for too long or whatever. But also, that is more for if the fetus isn't like at risk. That's your more what's the word? Like conservative management for slow progression. Whereas if the fetus is at risk, the only thing you can really do is cut it out. So emergency C-section is the only way to go. Okay, question 13. A 28-year-old woman who is 32 weeks pregnant presents with a blood pressure of 160/100 and 2 plus protein on urinalysis. In the waiting room, she begins seizing. Given the most likely diagnosis, what is the most important medication to administer? Yep, fab. Everyone's okay. Give it another minute. Well, not a minute. Okay, so everyone's who's answered has given me the right answer. So your magnesium sulfate. So there aren't many medications that you actually need to know too much about in obs and gynae. Obs and gynae is so specialized, especially the obstetric side. However, the ones that you need to know are your magnesium sulfate, your labetalol, and maybe your aspirin, I would say. So your magnesium sulfate is just your first line medication for a woman who is seizing due to eclampsia. Labetalol, it's a bit late in this case to be starting labetalol because labetalol is sort of what you'd be giving if they were like preeclamptic and you're like really worried about them. Or if they had eclampsia, but like they hadn't seized, I think that's just pre-eclampsia. If they're not seizing, I think that's just pre-eclampsia, to be honest. But labetalol is essentially like at the point that she's seizing, too late. You would still give it, but you would first want to stop the seizure. Blah 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 blah. And then aspirin, yeah, you can give aspirin, but it's more of an early preventative measure as opposed to a treatment. Oh yeah, there's my feedback form. Please fill out feedback. Let us know how we're doing. I will not dwell too long on this slide because I want to carry on. Okay, question 14. A 21-year-old male attends clinic for his test results after being treated for syphilis. Initial serology at diagnosis showed this. I'm not going to read it all out. Given the following results, what is the most appropriate next step? Okay, fab. So essentially, the only thing we really care about in this is your RPR. So this is like your dilution series thing to check at like how much syphilis do you have. And essentially, the higher the number, the worse it is because it means you've had to do this dilution series 32 times to get a negative result. Whereas if you're only having to do it 8 times before you get a negative result, that actually means you've got quite a lot less in your serum. And so obviously it gets to like a level where it's like not really causing, like it's basically not, it's negative. So yeah, so they actually have a cutoff which is which is a quarter, which is what we got here, 32 to 8. So with the EIA and the TPPA, they are normally always negative, always positive, sorry, because it remains positive even if you have treated it. And so you can kind of ignore that and just focus on the RPR. So more about this because I don't feel like, yeah, you do, I think you do get taught this, but like I personally didn't feel like I got taught this and I had to like learn it myself. So two types, so we've got two tests. You've got your cardiolipin tests, and this can be falsely positive because it's not always for syphilis, it's for other things as well. And that's like your VDRL and RPR. Don't ask me what it stands for. I don't know. I just recognize the letters, and I think this is actually really. Oh wait, no, it's not on the slide. There was something about A is always positive. So like your TPHA and your EIA, because they've got A's there, they're always going to be positive. I think that's a really good way of remembering because I was kind of lost back when I learned this. I didn't have that. So I think that's a good way of remembering which ones are meant to stay positive versus which ones should go down. And as I said, like this is like a dilution series. So the titers are used to monitor the response, check if they've been reinfected. Um, okay. And causes of false positives. Yeah, so as I said, it's not specific, the cardiolipin test, and so it can be with other things. So I've seen someone have like a positive syphilis, but then it's not actually positive syphilis. It's that they've been treated. It's a different infection that they were positive for, but I can't remember what that infection was actually. All right. Question 15. A 40-year-old woman presents with wheals on her skin. I don't think that's spelled right. That last for around 6 hours and then fade. They have been coming and going for about 48 hours and are causing her irritation. Which of the following would represent good practice at this stage? This one's quite hard, but like in like a silly way. It's hard in a silly way, I think. So I think it personally I would help me going into this question to know that I'm in GP. Which I think you put on your GP hat. Someone's come in, they've kind of got these wheals, which are these like red raised rashes. They come on, they fade away. They're kind of annoying her, but it's not really a big deal. You probably just reassure. Um, so it is no blood test. So this is urticaria. You know, the wheel is urticaria. So there's something that has triggered it. It's been going on for two days. So I would just ask her, like, have you are you, you'd run through like, have you been exposed to anything new recently? Have you, worn a different materials, all those types of things? Have you eaten something? Urticaria is just sort of your mysterious allergic reaction to something, and it's not really that you know problematic, and you can kind of recognize it from just physically looking at it. So if you saw like a picture of urticaria and you are, oh, see, it actually says here it's changed, presents to your GP practice, and you're sat in GP and you see urticaria, there's not really anything you can do. You'd maybe start looking into these things if they had like this prolonged urticaria. But if it's like, oh, this has been going on for 2 days, you kind of just you do conservative management, which is something probably triggered it. Find out what that is. Maybe you tell them to try antihistamines if it's really bothering her and causing her irritation. But you kind of start small before you start doing all these blood tests. Which is why I was like, this is a silly question in the sense that it's hard, but only because obviously as medical students, we're always going to kind of go for like the more like niche, oh, let me test this or let me test this. But I think it is helpful to know you're in GP. And I'm saying that as someone who wants to be a GP. So I'm not like being mean to GPs, but I'm just saying like you kind of, if you put your GP hat on, you're thinking like, am I going to jump to conclusions or am I going to go simple first and see if that works? And I like simple first. There's nothing wrong with that. Question 16. A 10-year-old child presents with a fever, a runny nose, a dry cough, a sore throat, and a very sore eyes. A rash is present on his face, and on examining his throat, you note the following appearance. What is the average incubation period of his pathology? So this is the side of the mouth. I don't know if that's super obvious, but like it took me a while of being like, why is the teeth oriented in that way? So this is like, like that. Not the tongue, because I thought it was the tongue at first. Okay, bit split. So what do we think this is? I also hate these questions, by the way, because I have had someone say that, but what do we think this is? Good, good. So we've got some measles. We've even got the specific finding. So what's this specific finding called? Yeah, Koplik spots. So personally, I would give you the mark just for getting your diagnosis and knowing that it's Koplik spots. You guys have done a good job. But I think the answer was a bit split because no one knows this because I mean, how many people do you see with measles? So it's not information that you get to practice very often, but I think it is worth knowing obviously contextually. If you got a job in peds, this matters. If you've got a job in GP, this matters. And so memorizing like all the incubation times and like how long they should spend off school and things like that is quite high yield and it is relevant, but only obviously if you're doing those specialties where you're more likely to see it. So I think it's understandable why this would be forgettable, but it's 11 to 12 days. So see, measles has an incubation period of 11 to 12 days, and like you have to be off school, I'm pretty sure, from 5 days from the um, rash, is what I'm trying to say. But and each of the, I don't know why this is in here, to be honest. I thought this was a peds question. All of the like infectious diseases, especially the pedsy ones, they do like to say like how long should they be off school and things like that, or do they even need to be off school? All very relevant if you are going to be seeing children. And so I would say like it's hard in terms of balancing what do you really need to revise. I would say revise revise your incubation periods and how long to be off school just for your SBAs. Obviously, it's not likely to come up on an everyday practice unless you're in a relevant specialty. There are some things that come up more often than others. And I think this is one of those infuriating things you just have to like memorize. But I mean, I'm not very good at it either. But good job for everybody getting measles. All right, question 17. A 24-year-old woman is 27 weeks pregnant. She has a feeling of fullness in one breast and is fearful of breast cancer from which an aunt suffered. Which characteristic would warrant her referral to a breast clinic? I've had one person say, I think it's 4 days from the rash, by the way, about measles. I would trust that person because they have probably revised measles more recently than I have. But 5 was close, so I'm giving myself. Okay, everybody's correct here, so we'll move on because I don't think this is too complicated. So, bilateral breast pain. She's pregnant. She's gonna have bilateral breast pain. Bilateral breast nodularity. Again, she's pregnant, so she's gonna have sort of changes to her breast, especially if it's bilateral. Not worrying. Breast pain with a fever. That would be not a breast clinic thing. It would maybe be like give her some antibiotics, maybe send her like to like a not like an A&E, but like a less than that urgent care center or something. But it wouldn't be a breast clinic because breast clinic is specifically we're thinking about like your 2-week wait cancer. Localized breast erythema, again, you'd be thinking, but it's not like you'd ignore it, but you wouldn't be sending it to breast clinic. The only thing that you'd be really worried about, especially in a 24-year-old, is your discrete breast mass. So some of these, I think, like the localized redness might might be within the criteria for an older patient because they are more suspicious in an older patient. But in a 24-year-old, I think below 30 is what I remember from the guidelines. Like anyone below 30, there's the only way that you can go to a breast clinic like a 2-week wait, like three, is it called three one stop clinic where you have the triple assessment? The only way is with a discrete breast mass. So that's like a very easy one to just learn because it's really hard to learn in like every referral criteria, especially with the breast stuff. But this one's an easy one to remember. Under 30 mass. It has to be a mass or they don't get sent. Question 18. Which one of the following features is a risk factor for breast cancer? Okay, fab. Again, you guys have all smashed it. So the thing, what is the feature that we're really looking for? Like the underlying thing that increases your risk of breast cancer? Perfect. Yeah. So estrogen exposure. So what we're thinking here is this is early menopause, this is late menarche. So actually, their estrogen exposure will be shorter. So you can rule out this. Body mass index is low. So obviously, if the mass index is higher, fat cells produce like more estrogen. And so you have more estrogen if you're obese, but not on body BMI of 24. Non-smoker, because smoking is bad always. So non-smoker is the opposite, not a risk factor for breast cancer. So we get down to nulliparity because essentially, if they have not had, if they're not pregnant, then that means that they're still having these cycles of hormone changes. So they're actually still having more estrogen exposure that way. And as I've said, yeah, I've kind of explained this. Okay, fab. I really like those questions, I'm going to be honest, because I love a question that you can think backwards about. So like, yeah. And you are right. So someone has said, I think smoking has no link to breast cancer. That the reason I know that that's true is because I was talking to my friend about like smoking increases like every risk of cancer apart from breast. So the only thing that is safe is your breast. Um, and she didn't quit, but I tried. So yeah, smoking is not linked to breast cancer, but it's generally bad. And so I was just saying that like think of it as the opposite. It's definitely not going to be not smoking is a risk factor for breast cancer. It just wouldn't make sense. But yeah, you're right. Smoking isn't actually a breast cancer risk. It's a risk of everything else. Okay. Question 19. A 32-year-old woman has been investigated after having 3 successive miscarriages. Tests have revealed she has high titers of lupus anticoagulant and antiphospholipid antibodies. Which antithrombotic treatment taken in her next pregnancy will help reduce her risk of further miscarriage? Amazing. Yes. So I'm not even going to ask you because I love antiphospholipid syndrome because they always tell you it in the question. So yes, this is also antiphospholipid syndrome. And so it's just what would you be giving her? And can you explain the risk? Okay, I'll come back to that. So yes, it is aspirin and low molecular weight heparin. And so I've got a question about could you explain the risks of cancer associated with progesterone versus estrogen? I keep getting confused. Um, I mean, off the top of my head, I'm trying to think. I don't think that I could be wrong, but I don't think that progesterone is a risk factor. I think it's about high versus low estrogen is what's associated. It's a good question, but I'm not actually sure progesterone is linked. Someone could definitely correct me if I'm wrong, but I think it's like things like your like endometrial. Oh, it's difficult. I'm trying to remember. Progesterone. Okay, here we've got progesterone. Progesterone increases the risk of breast cancer. Um, maybe because you can have PR positive breast cancer. Okay, so we do have some questions. Right, what I'm gonna do is I do not know the answer. So I thought that it doesn't. And the reason being is because, as you know, I know a lot about contraception, and I feel like it has been negated the idea that a progesterone only contraceptive increases the breast cancer. So like I have a reasoning for why I don't think progesterone does affect breast cancer, because there's no evidence to suggest that taking like the POP increases breast cancer. There's a theoretical risk, I think, but it hasn't been evidenced. However, that is kind of the scope of my knowledge. Progesterone on its own maybe could. Um, Essentially, what I'm telling you is I don't know, but I would lean towards it's mainly estrogen that you're thinking about, not progesterone. But I can maybe at the end I'll like have a look, have a think about it. But yeah, I'm sorry I'm not more helpful. You've actually really gotten me to think about it. I'm not really entirely sure. Um, oh, okay. I've got a really interesting way of like a way of remembering something here that someone's put in the chat. See, COCP harms the consonants, protects the vowels. So protects against ovarian and endometrial cancer and increases the risk of breast and cervical cancer. Interesting. I've never heard that before. I mean, I've heard the facts, but like not that as a way of remembering. But that's very helpful. Thank you. I might copy and paste that into the general chat because I think that is quite a helpful way of remembering. But yeah, I would forget about progesterone personally, but I'll maybe have a, oh, it's not letting me copy and paste. I don't know why. Okay, right, moving on. Sorry, I'm not more help with that one. That was a tough one for me too. Good question though. Question 20. A 30-year-old woman attends the surgery complaining of galactorrhea and severe pain in both breasts, despite having stopped breastfeeding 8 days ago. She has tried oral analgesia and bra supports and is about to return to work next week after maternity leave. Which one of the following drugs can be used to suppress lactation in this patient? Yeah, perfect. Everyone's getting this. Amazing. All right, so cabergoline is your answer. What is cabergoline? Yeah, perfect. So it's a dopamine agonist. And so it downregulates your prolactin. Um, what was I going to say about that? There was a reason I was asking you that. Well, I've forgotten. I was going somewhere with that, but I've reached the end of my thought process. Okay. And the other thing that I was wanting to say about that. Oh yeah. So obviously in this case, we've got like this is a bit of an unusual, as I say, it's not given routinely. So normally it's given to people who are really, really struggling with breastfeeding and can't do it. People who are on medications that they can't stop, but that kind of contraindicate them from breastfeeding, and also sadly people who have had stillbirths. So this type of situation is quite unusual. Um, but yeah, it's more in those other situations that it would be given. And it's just like a nice and easy one to remember. All right, question 21. So we're on to like the last two or three now. A mother brings her 1-year-old boy for assessment. She has noted his foreskin is non-retractile. There is no history of balanitis or ballooning of the foreskin. What is the single appropriate management for this patient? Hmm. Okay, so a bit of a mixed bag. A majority is still one, which is the right answer. So this is to be honest, I didn't know this. So but apparently you don't really need to do surgery. I would have so my thought for some reason my cutoff in my head was like you would wait a bit longer, but maybe to 2 years. I think that's because that's for something else. Um, but it's up to 10 years instead. Unless they're having complications. But essentially, you don't want to do surgery on someone if you don't need to. I think I'm trying to think like what is the 2 year thing I was thinking of? Because it's obviously not this, it's something else. That you wait for 2 years before you fix. I don't know. Do you guys know what I'm talking about? It's way more common than this as well. I'm just having like a brain. I think it's just yes, hernia. That's it. Thank you. Hernia. That's what you wait until they're 2 years of age before fixing. Fab. All right. Oh yeah, and lack or undescended testes. Thank you guys, because that was gonna bother me so much if I couldn't figure it out. Okay, question 22. A 48-year-old male patient comes to see you requesting screening for a chlamydia infection. What is the single most appropriate specimen of choice to aid diagnosis? Okay, fab. So again, everybody's got it right. So urethral swab you wouldn't really do unless they've got some discharge. That's my understanding. And then rectal swab you wouldn't really do unless okay, this is debatable. So in this case, it's maybe a little bit jumping the gun. Like there's a more simple way of testing for chlamydia than specifically testing for rectal chlamydia is like a step further. I think they do tend to like actually ask everyone to do mouth and rectal and then urine sample, like just blanket. So to be honest, it's a bit of a silly question to ask which one would you ask kind of thing. But you would do the first cast urine because that's sort of like your simple chlamydia infection. If it made it to the rectum, that is more complicated. So it's not like the simplest way of testing for chlamydia. And it's also like more in a high risk population. So for example, if they're having like anal sex, then there's like more risk of rectal chlamydia. But like if it's just like a bog standard, I'm just coming for a chlamydia test, it would make more sense to do the first catch urine first. Whereas this is more of like a targeted swab. It's not gonna come up positive unless they've got rectal chlamydia essentially. Whereas this one should come up positive for everybody who has chlamydia. Question 23. A 30-year-old woman has asymptomatic bacteria at 9 weeks of pregnancy. What is the single most appropriate next step in management? Oh, amazing. So you guys are all getting this right. This is a super important one because it's just so high yield. They love asking about which antibiotic can you give at which trimester. So yes, so it is nitrofurantoin. And what would you want to specifically I mean, it's kind of maybe given, but what would you want to specifically avoid in that first trimester? And for what reason? Yeah, good. Yes, perfect. I've actually gotten even more complicated answers than I expected. So yes, it's to prevent neural tube defects because it's an anti-folate drug, as people say. And so obviously in the first trimester, we're actually going to give folic acid, as opposed to the opposite. So it's like it's risking something that just doesn't need to be there. What would you want to give in the very last trimester? So yeah, so you can give so most of my answers are trimethoprim. What about like at the 36-week mark? Like when we're really close to term now. Yeah, perfect. So someone's got it. So the way that I remember it is nitrofurantoin for that first trimester, trimethoprim in the middle, and then right at the end is actually cefalexin that is preferred. Which is kind of it's less high yield. Really, you need to know it's nitro and not trimethoprim for that first trimester. That one's a really high yield one. But like the cefalexin, it used to pop up every once in a while. So that's why I thought that was worth um that was worth going over. Good question. I don't know. So I've got a question about why can't you give trimethoprim in the third trimester? I think it's just about which one. I honestly don't know. I don't know if I ever knew, or if it was just about I kind of yeah, I don't know. I know there is a reason. I know that there's a reason why you don't give nitrofurantoin towards the end of the pregnancy, but I actually don't know why they don't want to give trimethoprim. And if you ask me why don't we give nitro, I don't know because I don't remember. I just remember that there was a reason. Whereas I don't know about trimethoprim. It's just this is the pattern. Sorry guys. Question 24. Which of the following this is the last one. Which of the following antibiotics is associated with a reduction in the efficacy of combined oral contraceptives? Um, it's everybody's favorite question. Fab, yes. So it is indeed your rifampicin because we're thinking about our P450 inducers. Um, there's not really much to say about this. P450 will never stop following you around, so I would revise it before every exam. That's what I did. And yeah, I think everybody knows the mnemonic. I'm not going to say it because I think it's a bit mean. Okay, so thank you very much. Any further questions? And please do give me some feedback. I once this has been up for a while, I can quickly have a look at the progesterone. Or maybe because to be fair, I'm doing the session next week, so maybe I'll have a more deep dive than just a quick Google search into the whole progesterone cancer thing and get back to you because I think that's better than just kind of quickly Googling. Shout out to the person who told me why we don't give nitrofurantoin right at the end of the pregnancy, which is that it can cause hemolytic anemia. Perfect. Thank you so much. Yeah, sorry guys. I'm not entirely well. So I'm a little bit out of it today. And I'd like to say that that is my excuse for being slightly less